The final indication that I'd like to briefly mention is epilepsy. As you know, epilepsy is often treatable with pharmacological therapies. If they've got a definite seizure focus, you can either remove the temporal lobe, the mesial part of the temporal lobe, or you can remove an epileptogenic tumour or vascular malformation. But there are a significant number of patients that have epilepsy that don't seem to have a well-defined epileptogenic focus and that don't respond to pharmacological therapies. And it's thought that these patients might be suitable for deep brain stimulation. These are essentially the same patients that got the vagal nerve stimulators, which offer some patients a good benefit, but probably don't give as good a benefit as we would hope. So there have been a number of trials conducted, but the main trial is the Santé trial, which looked at bilateral anterior thalamic nucleus deep brain stimulation. They had over 80 participants. These patients had generalised seizures which had partial onset, so they had medically refractory seizures. They had a good median follow-up of 31 months, and they found that 60% of the patients experienced at least a 50% reduction in their baseline seizure rate, and the median seizure frequency was reduced by 2/3. So this was very encouraging, and there are now a number of centres starting to look at this for the treatment of epilepsy. We've only done one patient just because of the referral patterns. This patient was done about 2.5 years ago now, and he had Dravet syndrome, which is a myoclonic epilepsy that comes on during infancy. He had a range of intractable seizures. It was very hard to generalise and work out exactly which types of seizures he had, but he basically had every type of seizure that you could have. He had vagal nerve stimulation, which gave him a very modest benefit, and so he decided, or his family decided with him, that he would go down the path of deep brain stimulation. So we did intraoperative EEG monitoring, and what we found was that we could modulate his EEG patterns as we stimulated, particularly as we went out of the anterior thalamic nucleus and into the mediodorsal nucleus. We lost the ability to modulate his EEG, and he had a fairly dramatic effect in terms of his seizure frequency. But the thing that I noticed the most was that when he came back to see me in the rooms, when I saw him preoperatively, because he was having so many seizures, he was very, very drowsy. He just had this ongoing electrical activity. He was falling asleep in the chair. But when he came back post-op, he was quite alert. So that was probably the thing that I noticed more than the seizures themselves. So. The second big psychiatric condition that's being treated with deep brain stimulation now is obsessive compulsive disorder. This isn't as common as depression, but can be equally as devastating for the person affected and their family. These patients have recurrent obsessions and compulsions. This condition often manifests during adolescence or even childhood, and it can often get worse with time. Fortunately, 90% of these patients can be treated with psychological strategies and pharmacological therapies, and so most of them don't actually need to be considered for surgery. OCD does have a fairly good base of literature when it comes to surgical treatment, and most of those studies have been done with lesioning, either open lesioning surgically or with stereotactic radiosurgery such as the gamma knife. And if you look at the results there, I've just summarised really the response rate. The thing to note on that slide is that the response rate does vary quite a lot. And it's not particularly great, but it's not too bad. But when deep brain stimulation became accepted for other conditions, it was logical to look at applying it to the treatment of OCD. Again, like depression, you're looking at multiple targets that can be selected on the basis of our knowledge of the pathophysiology of OCD, on the basis of functional neuroimaging studies, and on the basis of response of obsessive compulsive disorder traits and signs to stimulation for other conditions, such as patients with Parkinson's disease might have had STN stimulation and their OCD features got better, so people started looking at the subthalamic nucleus. So again, the response rate there, when you look at the literature, does vary, but you're probably looking at around about 50 to 60% of patients responding. We've done 3 OCD patients. We've done a lot of patients with Tourette syndrome that have also had some OCD features, but we've done 3 patients primarily for the treatment of OCD. One of them was done last week, so we don't have much follow-up on that yet. But the 2 patients that we do have follow-up on, one patient had significant Tourette syndrome and OCD, and we decided to put electrodes in the bed nucleus of stria terminalis as well as the globus pallidus internus, with the rationale being the GPI was the target for the Tourette syndrome and the BNST was the target for the OCD. She has obtained a significant benefit, particularly when at home, but unfortunately when she goes out in public, her tics come back. So she's got a partial benefit. Her OCD symptoms are not as pervasive or as repetitive as they were before, but the great thing for her is that she's been able to substantially reduce her medication intake. The second patient also had an improvement in her level of functioning and a reduction in the number and frequency of distressing thoughts. So we're still going through those, trying to quantify things for those.